Okay, thank you. Thank you to the organizers for having us here. Look forward to presenting a little bit more about Kiora Pharmaceuticals. If I may start with a forward-looking statement, it actually is a real pleasure to be in a room where we are talking about approved products. It's been a long time coming, but my forward-looking statement is going to be, I look forward to being here, assuming you're going to have me and continue to do this, an approved product in a few years' time. So moving forward into, well, what could those products potentially be? We are obviously a public company. We have two active programs, both of which are small molecules to treat different retinal diseases. They are very independent of each other, and I'll walk you through both of them. One of our programs, our 301 program, we have a fabulous partnership with Laboratories Théa, based out of France, and that has been going incredibly well as we continue to advance that program. And the other, actually very positive thing I can say today, outside of some of the pessimism we heard earlier this morning, is that we're not raising cash. We have enough capital to get into late 2027, which is truly a great place to be in this time of this, what we could say, a market storm. So at a high level, a look of our pipeline, again, two active programs, one of which is in inherited retinal diseases and the other one is in retinal inflammation, both of which have been approved to initiate phase 2 clinical trials. One is a 2B study, which I'll walk you through briefly, and the other is more of a 2A general design. Starting out with our Kiora 104 program. This is based around a small molecule DHODH inhibitor. For those of us that are not as familiar in the autoimmune space, DHODH is a validated target with respect to T cell activity in diseases like RA and MS. We have been able to take our third generation DHODH inhibitor, formulated as an intravitreal injectable product, and then therefore develop that for different retinal approaches that have inflammation in a way to steroid spare, if you will, these individuals. For those that don't maybe remember their Bio 101 days, our DNA and RNA is made up of pyrimidines and purines. What we're able to do with the DHODH inhibitor is block de novo pyrimidine synthesis, which is what T cells rely upon as a way to rapidly proliferate, driving inflammation, as well as a cofactor in multiple different pro-inflammatory processes. We ran a study in posterior non-infectious uveitis. This was a phase 1B study, if you will, that showed improvements in things like cystoid macular edema, as well as correlation to improved visual acuity, almost getting up to about 3 lines. Switching, or now moving into what will be our upcoming phase 2A study, this is more of a bucket oncology type approach to look at different diseases that all have the same symptomology, if you will, of macular edema and therefore reduced visual acuity. We're going to be treating patients in a few of these different indications and then moving into more of a dose expansion phase for the study. And now switching over to our Kiora 301 molecule, this is the exact opposite with respect to mechanism of action. This is a very novel approach that has never been done before, but walking through what does the molecule do. The molecule itself is based around an azobenzene core. And for those biochemists in the room, azobenzenes are notorious for doing isomeric shifting. In the case of our molecule, this is a reversible isomeric shift. It is able to gain entry into the retinal ganglion cell, and specifically those that are downstream of degenerated photoreceptors, where then it lodges in a non-covalent way to the intracellular domains of HCN and potassium voltage-gated ion channels. When light hits the molecule, what we see happen is it changes shape. It therefore alters ion flux across those channels and causes that ganglion cell to depolarize and signal the brain that light is present. You take light away, it reverts right back and repolarizes the cell, stopping that signaling. We have shown this through multiple in vitro and ex vivo and in vivo studies. Here's just one showing when you cycle light on and off, you generate neural trains that then correlate directly and rapidly with that light shift. That led us to a phase 1B clinical study that we ran in later stage RP patients. Obviously, they have degenerated photoreceptors, but their ganglion cells remain intact. And what we saw was in this open label study, no matter how we looked at vision, it improved. And it did so in a way that correlated with the pharmacokinetics of this molecule, because like all small molecules, it gets cleared. So this is going to be a repeat injection, unlike gene therapies, but we think this has a lot of advantages to those gene therapies. We did functional MRI. We saw the visual cortex specifically light up. that also correlated with that same timing approach. That is now leading us to a phase 2b study, which we are kicking off and we'll start enrolling pretty shortly here, and very excited for that. So with that, thank you.
You mentioned the on signal with light. Is there additional light to be provided here, or this luminance light is just fine?
Yeah, so the lighting itself, so the question was, I guess you heard it, the light is actually visible spectrum light. So there's no amplification, there's no filtration, there's no correlating medical device, if you will, or optics device that's needed with this therapy, we believe.
How does 301, the photo switch, select for the bipolar cells?
So it doesn't. It selects specifically for the ganglion cells. But what we're seeing happening is in cases of retinal degeneration, you have an upregulation of something called P2X7, which is a neuroinflammatory marker that's actually being thought of as a druggable target in certain neuropath diseases. What we see is where there is degeneration or no photoreceptors left, that is upregulated on those downstream ganglion cells, and that is the conduit by which the molecule gains entry into the cell.
It's a very novel mechanism. I don't know much about it, so I'll ask this question. Retinal ganglion cells are also extensively affected in our popular diseases of AMD. Is there a role for this?
So it's a good question. We do think certain age-related diseases, there could be the potential to actually augment vision by having a small molecule like this on board. Obviously, glaucoma, very different case, right? Late-stage glaucoma, disease of the ganglion cells. If those are gone, we're not going to do anything. So with respect to the neovascular AMDs, possibly.
Thank you, Brian.